Hi everyone, welcome, 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 welcome. Gonna get started nice and soon. My name is Harrison. I'm your host for this evening. You can see our incredible panelists waiting to go as well. I know you've got some red hot questions for us and we're ready to answer them. So we'll give it a few moments and I think we'll get started. Hoping that wherever you are at the moment, you've had a good day and that it's been a bit of a cruisy afternoon for you. We're going to make sure that tonight's quite entertaining as well for you. So hopefully you're all looking forward to that. Feel free to say hello in the chat as well. The chat is live. So feel free to let us know where you're zooming in from. Also love to hear from you. I can see some familiar faces in the chat, which is wonderful. Welcome, welcome, welcome. Brilliant. In our neck of the woods, Alessandro, lovely to see. Excellent. Amazing. Western Sydney, my hometown. Welcome, welcome. Thanks for zooming in. Awesome. Brilliant. From the Gong as well. Great. I feel like we're covering lots of ground here already. My goodness, this is awesome. Excellent, excellent. We'll give it another 2 minutes. I think we'll kick off. Brilliant. A lot of Sydney siders. That's always good. Brilliant. Newcastle as well. Welcome, welcome. Awabakal country. Brilliant. Excellent. Brilliant.
Hi, everyone. I made it in time.
Hello, hello, Steve. Welcome, welcome. We're just giving it a 2 more minutes and we're going to get started, but we've got people zooming in from all over New South Wales, which is really exciting.
Awesome.
Welcome, Billy. Welcome, welcome. Excellent. We're also streaming live on Facebook, which is exciting tonight. So I know that David from ACON is also watching that stream. So I'm sure we'll be getting some questions coming through from Facebook, which is exciting. Brilliant. Awesome. Okay, so we're going to get started, I think. So welcome, everyone. Before I begin tonight, I would like to acknowledge the traditional owners on the lands on which we're meeting today. I'm calling from Gadigal country and would like to pay my respects to elders past, present, and also pay my respects to elders past and present from the lands and countries of which each of you are connecting from today, and as well as pay my respects to any Aboriginal or Torres Strait Islander people joining us today. These are stolen lands that were never ceded, always was and always will be Aboriginal land. So before we crack into the main event tonight, I just want to quickly go through some housekeeping. So the session is being streamed on Facebook. High tech, I know, we'll cope. And also we are recording the session as well, so that if anyone hasn't been able to join us this evening, they'll still be able to access it after the fact, which is really awesome. So we do have the chat enabled tonight, so please feel free to have a chat with one another as we go through the evening. Please be respectful and kind to one another. This is obviously a community space, so we want to make sure that everyone's safe and well looked after. So please keep that in mind. If you do have a burning question tonight, I would ask that you use the Q&A function. And that's going to mean that even if we're having fabulous chats in the chat box, that your question gets through to our panel straight away and we can answer it for you without delay. We do have 2 moderators on tonight. If I can get them to quickly pop their cameras on for a second. So we have the incredible Amber, whose pronouns are they, them, and the awesome Tim, whose pronouns are he, him, from ACON. So they will be answering any of your questions as well that you type through that the panel responds to tonight. And if you do need any help throughout the evening, just please get in touch with either of them. We're also joined by two incredible Auslan interpreters tonight. Lizzie, whose pronouns are she, her, and Leah, whose pronouns are she, her. Thank you so much for being here, and it's awesome to have you here. This event is a collaboration between ACON and the incredible volunteer-run grassroots organisation Sydney Bi+ Network. The network is dedicated to improving the well-being of Bi+ folks across the Sydney area through community building, education, and advocacy. And they do an incredible amount of work, considering that they're all volunteers and are a grassroots organisation. So thank you so much for the collaboration, and we really hope that everyone enjoys tonight and this collaboration. If you or your friends haven't connected into the network before, please feel free to connect and say hi. I'm going to be sending out information after this forum, and our moderators also will potentially share some links for you to kind of click through and get connected, and hopefully share amongst your friends as well too. Awesome. So with the housekeeping out of the way, let's get you introduced to our panel. Mandy, hello. So everyone, this is Mandy. Hi, Mandy.
Hello, thanks for having me.
It's a pleasure. So Mandy is an Aboriginal biosociologist of health, sexuality and gender at the School of Social and Political Sciences for the University of Sydney. And Mandy has a strong history of advocacy and research in gender and sexuality, and often uses a critical or queer lens to bring forth marginalised violence. Some projects that you've worked on that you talked me through include investigating lived experience of people with intersex variations, lived experiences of dual marginalised identities, specifically Aboriginal and LGBTQ, young people and body image, Aboriginal people and cancer treatment in Australia, and Aboriginal people workforce retention as well. With a background in sexual health, mental health, public health and education, Mandy brings a truly multidisciplinary approach to the panel, as well as their own diverse lived experience. So it's an incredible pleasure to have you here. Thank you so much, Mandy, for joining the panel tonight. I hope I got that bio right. We're also joined by Phil Reid, Dr. Phil Reid, pronouns he, him. Phil is a sexual health physician and the Director of Sexual Health and Bloodborne Viruses in South Eastern Local Health District, which includes Kirkton Road Centre and Sydney Sexual Health Centre, Albion Centre and Short Street Sexual Health. So a lot of responsibility, and no doubt you're incredibly busy. So thank you so much for being here tonight. Phil has also been involved in the rollout of the vaccine programs for monkeypox in New South Wales as well. So thanks for joining us tonight.
Yeah, thanks for inviting me. Yeah.
We're also joined by Eloise Monterio, pronouns they, them. Eloise is a bi-volunteer community organiser with Sydney Bi+ Network since its beginnings in 2018. Through holding community events and consultations, Eloise has started many bi conversations in the sexual health space. Eloise has enjoyed hearing hundreds of community stories and believes it's important to understand the bi community's collective experience to improve support for bi health through community-led approaches. Eloise has experience working in diversity and inclusion, biomedical research, and HIV health promotion. Welcome, Ellie. Amazing. And last but certainly not least, the illustrious Steve Spencer. So Steve is a bi-HIV advocate. He holds a number of roles in Australia's HIV and LGBTQI+ health sector, and is a co-founder of the Sydney Bi+ Network's HIV project. Steve seeks to use collaborative approaches to health equity by bringing community together through community research and also policy development. He was recently also awarded an ACON Honour Award for his work in combating biphobia, bi-erasure, and HIV stigma and discrimination. Steve, as you can imagine, has a wealth of lived experience, specifically also around monkeypox infection, and has advised on several monkeypox campaigns and research projects as well. And my name is Harrison. For those of you who don't know me, my pronouns are he and they, and I'm the team leader of ACON's peer education programs. I've worked at ACON now for nearly 6 years. Grew up in Western Sydney, so represent the person from Western Sydney, and am passionate about ensuring that equity is really hard baked into everything that I do at ACON. And so over my time at ACON, I've worked to support my immediate and broader team to address historic inequity and barriers of access that have and unfortunately continue to still exist within both within ACON but also external to ACON as well. And this collaboration is an important step forward to ensure that ACON's work meaningfully supports bi people's health and well-being. And again, a huge thanks to the network for partnering with us on this one. Alrighty, so we're all very qualified. So with those incredible introductions out of the way, I just want to give a little bit of background to our audience around how this forum came to be and why we're talking about monkeypox. So globally to date, there's been more than 80,000 reported cases of monkeypox. And within Australia, there have been 143 reported cases confirmed and probable. And that's since the 25th of November. So of those 143 reported cases in Australia, 56% of these cases have been reported in New South Wales. So in terms of the rollout, just again for a little bit of background and some history. So since August 8, New South Wales began vaccinating people who were deemed highest at risk for monkeypox. And that was a really, really limited rollout as vaccine supply globally was really limited. We only received a very, very small amount. Since October and the arrival of an additional 25,000 doses of vaccine arriving in New South Wales, we've seen expanded access across New South Wales to the vaccine, but also now to the criteria, which kind of prompted this forum because we need to talk about what that means for the bi community. This shift in availability and broadening of access is pretty big news. And so we want to talk about it, which is the gentlest of segues for me to start grilling Phil with some questions, all things monkeypox related. So Phil, for those of us who haven't heard about monkeypox, what is it?
Just literally at that moment, my phone started ringing. It's going to ring out in a second. Just turn it on.
No worries at all. It's like, hello, monkeypox calling.
Sorry, let's start that again.
No, that's all right.
Something about monkeypox, yes. So what is monkeypox? Look, first of all, just look, thanks to you and thanks to the bi community for inviting me to speak and participate in this evening. I'm really grateful to be offered the opportunity to talk, and I'm obviously happy to share you know, my experiences from a medical practitioner perspective and somebody that works with community, but also I'm pretty confident that looking at the chat already and the other panelists that I'm certainly going to learn a lot myself this evening, and also, you know, really happy for any questions, even if they're challenging questions. I'll do my very best. So where do we head with this? Well, look, to the medical community and to the world largely, up until quite recently, what we've called monkeypox, or what the World Health Organization, as of I think about yesterday, would like us to call Mpox, was a very, very, very rare disease. Most doctors and nurses would go their entire career without even having heard of, probably, or certainly having seen a case. It was discovered in the mid-1950s, and it was discovered in monkeys, and that's why it was called monkeypox. In fact, there are other animal diseases that are named after the animal that they were found in. So there's cowpox, of course, there's canary pox. This was monkeypox. And in the 1970s, it became apparent that, in fact, humans could contract this infection, but it stayed very localized, very, very specific. And for most of the last 30 years, it was a rare and isolated condition that occurred in some parts of Central and West Africa, with sporadic importation into other countries through travel, movement, not particularly thought to be sexually related, mostly travel, close contact, and so forth. There were a couple of very small outbreaks. A bunch of prairie dogs caught it in the United States, and it infected a couple of people, but it died out. Now,
I was about to say, Phil, because as we all know, prairie dogs love sex. They're very active. Those prairie dogs.
They're very sex positive. Prairie dogs.
Liberated.
So look, and that's kind of interesting actually, because we don't really, there's not a lot of investment in infectious diseases that affect developing settings. And because monkeypox was an infection which predominantly affected people in underdeveloped settings in Central West Africa, there's not a lot of research on it. So we don't really know where the natural host is. It's thought that it's in rodents. Okay, so it's thought that wild rodents in some of these places may harbor the infection, and it's sporadically transmitted to humans. So then fast forward to May this year, and of course, the first cases in humans in this outbreak were recognized in the UK, and somebody that may have traveled from the sort of Nigeria area. And then very shortly thereafter, it became apparent that in fact the infection had begun to spread through, at this stage, a fairly tight group of sexually active, predominantly gay men. But the data on that, of course, typical of this was the sexual histories of those individuals and their sexual identity probably wasn't initially explored in full detail. Probably people were reporting or presenting to places that didn't routinely ask those kind of questions. And so over the next few months, as you'll all be aware, it began to spread through the UK, France, North Europe, and then it hit North America. And we got to the point by mid-July that we were having up to about 1,000 cases a day diagnosed globally in an infection which normally would only cause a handful of cases each year, and certainly very few outside of Central West Africa. We had, I think you alluded to it, Harrison, we did start to get a few cases in New South Wales, again, sporadic. Of the 50 cases that you reported, or the 56 cases that you reported that were diagnosed in New South Wales up until the 25th of November, we think 50 of those were people who acquired the infection overseas in a country where it was more common than in Australia, and probably maybe 6 were locally transmitted. Now, in any infectious disease, I'm sure some of you were COVID contact traced at some point, either through the dysfunctional Commonwealth app or through normal contact tracing using humans. We've done a lot of contact tracing to try and identify known contacts. We've only found about 35 known contacts of those 56 people in New South Wales, and maybe about 90 low-risk contacts. So there's not been a lot of secondary transmission within New South Wales. So globally, from those 1,000 cases a day, in actual fact, since probably 2 things, since vaccination, but probably equally, if not more important, thanks to community awareness and probably some behavior modification, the numbers of cases have really dropped over the last few months, in fact. And so we're only getting about 100 cases a day now in globally, which is 1/10 of what it had been at the peak. But as you'll all be aware, through COVID, infectious disease cycles tend to go up and down, and you can end up with all sorts of waves, and you think you're over it, and then suddenly you realize you're in the middle of it again. So I wouldn't count our chickens too much, but it does give us a great opportunity to have meetings like this, to talk about prevention, to talk about vaccination, and also symptom recognition. So I know many of you may well know bits and pieces about monkeypox, so apologies if this is telling you stuff you already know. But generally speaking, monkeypox is thought to be spread through either respiratory droplets, which is, coughs and sneezes, and don't think about it too hard, the bits of spit on surfaces and things like that, or through close physical contact. And that's what traditionally it was thought to be. But in actual fact, the overwhelming majority of transmissions within this cluster of 80,000 global cases seem to be from intimate physical contact. It doesn't require everybody's definition of sex, but it requires some level of physical contact for a reasonable period of time. And in fact, whereas previously the infection was described as causing a number of pustular lesions, so like red spots that develop pus in them, sometimes break down into painful ulcers, often elsewhere on the body, so often the forehead, the arms, the trunks. In this particular outbreak, there's been a high proportion of people presenting with genital lesions on their penis, around the anus, on that vulva, sometimes in the oral cavity, and a less predominance of general poxy lesions elsewhere in the body. Can be accompanied by fevers, lymph gland swelling, so swollen necks, swollen groins, swollen armpits, headaches, fatigue. And typically that should start between about 4 days and 21 days after exposure. And those lesions should, or according to the literature, be starting to fade and disappear with scabbing, and then normal skin under there after about 3 to 4 weeks. Now, it can be extremely painful. And some people have, about 5 people in New South Wales have needed to have an overnight stay or 2 in hospital, often to manage pain. It can be to manage severe pain in the bum and bleeding in the bum because of infection in that area. Sometimes it can affect the eyes, sometimes it can cause problems swallowing. So it's a very serious disease. The global literature described in some cases like a 2 or 3% mortality rate from this infection. I think it's fair to say that in the 80,000 cases that we've had globally now, very, very fortunately, that's only eventuated in about 50 to 60 confirmed deaths. Obviously very sad for those people and their loved ones, but you know, more like 1 in 2,000 people may die from it rather than 1 in 100 or more, which was originally quoted, but still very significant symptomatic infection. So recognition, I'm sure we'll talk about recognition and where you can access treatment or where you can access testing in the chats, but obviously sexual health services and highly aware general practices are testing people for this infection if they present with risk factors and relevant symptoms. But testing should be available throughout New South Wales through a variety of laboratories. And then I guess you alluded to it at the end, Harrison, the game changer really for us in terms of management was the arrival of the vaccinations. So it's been a couple of years of vaccination for all of us, I think. You know, I was obviously particularly delighted to need to help roll out another vaccine program on the wake of the COVID one. But at least this one was a bit more related to my area of interest, which is sexual health. So it's very happy to contribute to that, although, you know, rather obviously it wasn't necessary. So we got those 5,000 vaccines, and they really did need to be prioritized for the people who the data showed were most at risk of catching it. You know, we estimated that within New South Wales, there might be 50 to 100,000 people who might be eligible for the vaccine, and we only had 5,000 doses. So we really had to go hard on choosing people or offering it to people who are of the highest risk. But really, since we've managed to get the 25,000 doses at the end of October, and also crucially, since we've learned that we can give 1/5 of the dose into the skin rather than into the soft tissue below the skin, we can extend that 25,000 out to the 100,000, out to about 100,000 doses, which is probably enough to cover the possible at-risk population. So vaccination is 2 doses, 1 today and 1 in 28, or 1 28 days after that.
That's
so
excellent.
Yeah, so I mean, I guess, Harrison, I guess I could leave it there, and we could talk a little bit more in the panel, but that's, I guess, the background of the medical and the vaccine process as to how we got to where we are today.
Excellent. And so just really quickly on that, you know, rightly, I think within many communities, but also within the bi community, there was, you know, and I'm sure the panel can kind of talk to this, and we'll kind of come to this a little bit later, but there was a lot of confusion and concern around who was at risk and who can even access the vaccines, because it was such a concentrated rollout. With the change of criteria, what does that mean now for bi community members?
So the current criteria very much focus on with whom you're having sex. And so anybody who's having sex with somebody who might be at risk of it is eligible now for vaccination. So the actual criteria, not necessarily written exactly by me, but the actual criteria say something like cis or trans men who have sex, or cis or trans gay or bisexual men, or anybody who is having sex with individuals in that group. So that would be inclusive of women having sex with cis or trans bisexual or gay men. It would be inclusive of non-binary, transgender people. It's also now inclusive of sex workers, in fact. So originally, sex workers were only eligible if they were likely to be having clients from a high-risk group, or in fact, you know, obviously in their personal lives they'd be eligible, but now sex workers are eligible through their profession as well. Not that we've had cases in sex workers in New South Wales, but obviously we need to make sure that we provide opportunity for that population to afford themselves the best protection possible should it get into that population.
Excellent. And I think that's a really good kind of segue to just really quickly lean in on the details around vaccination. So what vaccine do we have availability to, and what do we need to know about it?
Yeah, so we're quite lucky. We didn't have any really in the country, to be quite frank with you, when all this started. And there was a lot of backroom negotiating, I'm sure, between the federal government and the manufacturer. So the new vaccine, it's a smallpox vaccine. So smallpox is structurally very closely related to monkeypox. And therefore, the vaccine against smallpox confers a high level of immunity also to monkeypox infection. Now, there was an older smallpox vaccination that people may remember caused the scarring on the arm. It required this contraption to kind of stick it in your arm, and you had to create a scab, and it's kind of a little bit gruesome. But I mean, it worked really well, and it saved, you know, millions of lives. But it was an unusual kind of vaccine process. We hadn't given it in Australia since the 70s, and really the only people, yeah, because smallpox was eradicated or declared eradicated in the early 1980s by the World Health Organization. So the only people who accessed this vaccine were either like, you know, super secret service troops who might be subjected to biological warfare, or laboratory workers who worked on samples of smallpox which were still in existence in Moscow and New York, for example, or people who worked in potential bioterrorism outbreak scenarios. So those people got the vaccine, but nobody else really. The issue with that vaccine is it caused a lot of side effects. It caused what's called myocarditis, particularly in young people, inflammation of the heart. It was a live virus, so you gave it to somebody, it replicated in them, and in fact could be transmitted to somebody else. So it was really very difficult for any community that had people living in it that may have some level of immune compromise. So, for example, people living with HIV would be susceptible to, you know, significant side effects from this live vaccine. So that's not the one we've got. The one we've got is called Ginia. Yes.
As much as I want to feel like a super sexy spy, yeah, I don't necessarily want all of those hang-ups. I don't know about the panel.
So this one doesn't cause that, right? It is a live virus, but it doesn't replicate. You can't give it to anyone else, and it's not going to replicate within you. Safe in people living with HIV or people with any immunocompromise, safe in a whole variety of situations. We think that one dose probably gives about 80%, 75, 80% protection against monkeypox infection, and 2 doses is what you need to complete the course. So it's, yeah.
Great. And so like PEP, PrEP,
Hmm.
T, any gender affirming care that you might be engaged on as well, that's not going to interact with the vaccine at all?
No, it's not. In fact, it can be given with pretty much any other medication or product that people are using. Can be given with other vaccines, although if you give it at the same time as another vaccine, you may not know which vaccine made you feel unwell.
Oh.
So people have tended to separate it out. There is a caution around the heart thing with people who've just had a COVID vaccine, but that's really just a very minor precaution. We've not seen any issues with that. The commonest side effects are at the injection site. So given in the subcutaneous way, about 50% of people do get a red itchy lump at the site of vaccine, which can last a few weeks.
And is that the on the arm, or is that in the shoulder? Sorry, I've forgotten my medical know-how.
So subcutaneous means under the skin.
Oh,
so
okay.
That's the one that's given in the shoulder always.
Right.
And then the intradermal is where you prick it into the skin layer itself and cause a little blister almost, like called a bleb. Now, we started doing that in the forearm, okay, but it causes a very high rate of redness and irritation that can last for weeks and weeks and weeks. And I think very rightly people pointed out that may be disclosing of some people's sexuality or just that they'd had a vaccine anyway. And so we've started over the last month or two to give that also in the shoulder. So we give it in the shoulder, but in a slightly different way. But that does cause slightly more side effects in the skin. But overall, no worse side effects. And out of the 20,000 doses of this vaccine that we've given in New South Wales, I think something like 3 people visited an emergency department afterwards, and they were told they were fine. They just needed a Panadol, like any kind of vaccine.
And a shawl as well, if you're getting if you're in a singlet like I usually am, and you want to kind of keep things on the down low, you just
probably
got or something.
Better develop deltoids than me, Harrison.
I severely doubt it, Phil. Look, I think the kind of key question here to kind of wrap up our vaccination talk is around access and specifically around Medicare. So how would I go about, so if community were like, great, awesome, the criteria is broadened, that's for me and my partners, where do I get the vaccine? How do I make a booking? And then also, do I need to be Medicare eligible to access it?
Yeah, first thing I will just say is I really just want to acknowledge that the rollout of the vaccine happened as quickly and with the best intent as possible, but because of the speed, and nobody had ever seen the vaccine in their life before, with no system to roll it out, there were probably some, spur of the moment or urgent decisions that left some people confused. The criteria changed sometimes. The way we wished to book people in and asking about priority, could have been seen as unnecessarily probing of people's personal details. So, the community responded incredibly well around that. But I do recognize that not everybody, felt comfortable filling in those details. So the good news is that's not necessary anymore. There is a centralized New South Wales Health website for working out where your local vaccination clinic is. We run the one at Crown Street, but there's one from St Vincent's Hospital and there's one at Royal Prince Alfred Hospital, which are large centres. But in every local health district now, there should be access to vaccination, and it's all sort of centrally booked. You will get some follow-up questions if you have the vaccine, which is, we've never given this vaccine in Australia before. And in fact, it's not even formally approved. We're giving it through emergency public health legislation. So we're keen to make sure that we're not causing unexpected harm. So people may get an SMS after they've had the vaccine a couple of times to say, hey, how did it feel, etc. And we're also super keen to see if it actually makes a difference to the community as well. So there is also a research study, which I'm a contributor to, called the TREX study, which asks people questions after vaccination, or in fact asks questions of people who've yet to be vaccinated. about their symptoms, whether they've been diagnosed with monkeypox or not, and so forth. So we're working hard to try and build a solid data set to make sure that people are given the right information and that we learn from this experience.
Excellent. And you don't need to be
Sorry,
Medicare
no.
eligible either. No, that's okay.
No.
I gave you 3 questions, which is like
No,
the cardinal
you
rule
led
of
me to
asking
that question 3
questions.
times. I kept forgetting. So no, absolutely not. Completely free. You don't have to have Medicare. Now, we would like, with your permission, to put your vaccine into what's called the Australian Immunisation Register, because that helps us track who's had it and safety issues. However, we will be very happy to vaccinate people who don't want it to go in that system for whatever reason. Maybe they don't want a record of that vaccine in the federal system, or that other people might be able to theoretically see. And for some people who work in the sex industry, we've been happy to vaccinate them under sort of whatever name they're keen to give us. So we don't sort of, photocopy your ID and check that you really exist.
Excellent. And, walk-ins, I know that a number of clinics have mentioned to me, if the booking system feels overwhelming or, just not accessible for some people, walk-ins are still also an option as well. Is that right?
I can't speak for every vaccine centre in the state, but certainly the one we operate at Crown Street, yes, walk-ins are very much welcome. We've seen lots of people through walk-in. Now, obviously, there's a small risk that we might be overwhelmed and can't see you that day, but we should tell you that up front. But yeah, walk-ins are fine.
Excellent. And so I suppose another quick question that has come up from community that I did also want to flag is, say we're living regionally or remotely and we're getting all of our care provided through our GP as our first point of contact. If we're concerned that we've kind of come into contact with monkeypox and we need to seek testing, what's the process around that? And do people need to be thinking about testing at this stage with the numbers being where they're at?
Well, look, I think that 50 out of the 56 cases were from overseas transmission, and the majority of those individuals were pretty health literate people who often presented themselves to services, and in fairness at the start probably had to advocate for being tested. However, if somebody feels that they have been at potential risk, then there are a number of first-line tests that are done, but there are what are called epidemiological risk factors and clinical risk factors for the infection. If you fulfill some of those, then testing is done. It's a normal swab test. If anyone's ever had a swab for, well, no, it's not quite like COVID, but for something like chickenpox or herpes, it's just a cotton wool swab that's rubbed on the sore, which, I acknowledge could be quite painful. Any laboratory can get the test done. Any GP can order the test, but they, if they haven't got experience, they may need to call a helpline and get them put through to a sexual health or an infectious disease physician. But there should be access to testing through every medical practice in the state. But I acknowledge that not every general practitioner is going to be 100% up to speed, and that may be more acute in regional remote areas than, for example, in Newtown, Darlinghurst or Marrickville.
Excellent. And a community members just mentioned as well in the chat that, the track survey requires testing as a part of that process. So
it doesn't require testing.
Okay.
When you get the survey, it kind of says, have you had monkeypox since we last saw you? Have you had a test for monkeypox since we last spoke to you? And have you had a second dose? And then it asks you about partners. And if you've not had monkeypox, not had a second dose, and you haven't had what we might call casual fuck buddy type partners, then the survey takes about 30 seconds. If you have more than that, then it does ask you more questions. Yeah.
Awesome. Thank you so much. Brilliant. I'm going to push us on just because we are on the clock, unfortunately. Otherwise, I feel like we could be here chatting for hours, which is, I would like that, but I don't know if everyone else would. All right. So let's open this up a little bit to the panel. So Mandy, Ellie, Steve, we've gone through COVID. So that was an experience. And now we need to navigate this new virus that's in town, thankfully in very small numbers, and with vaccination now being open to us, which is helpful. I'm curious, when did you each first hear about monkeypox? Who'd like to go first?
I can go first.
Yeah, go for it.
I heard about it through the news. So not through any particular health promotion platform. And then I first heard about the vaccine and stuff through originally the vaccine through my partner, and then through friends who were very community connected about the changes to the criteria.
Awesome. Mandy, Steve, what was your experiences like? When did you first hear about it?
It's hard to sort of pinpoint exactly when, because my concept of time is not fantastic, but it was quite a few months ago, I guess, when the media started talking about it quite a bit. So I sort of started hearing about it through there, and then through, a lot of advertising from sexual health organizations. I didn't really see any other bi people talking about it, nor was any kind of media or health promotion messages targeted towards bi people. So it all seemed very focused strictly on gay men. So that's sort of where I kind of first heard about it, and the context that was kind of being presented at the time.
Interesting. Steve?
Yeah, same as Ellie. I definitely heard about it a lot on the news, and then it was being discussed fairly deeply within, especially my gay male networks, but less so, absolutely less so within my bi plus community networks. And so it looked like a big concern for people, especially a lot of people were traveling overseas during winter. And like I was traveling over to Canada in late July, and definitely front of mind was there are huge monkeypox numbers in Canada. How do I protect myself? What sort of things do I need to put in place to ensure that I'm safest? And so that sort of gave me a crash course in what monkeypox was and how I can protect myself and people around me. And yeah, and then coming back to Australia, I was then diagnosed with monkeypox after getting it overseas. And the discussions here were very much by that point discussing the rising number of cases, discussing a lot of people talking about limiting their the number of their sexual partners. And then of course, with the vaccination rollout, everyone I knew, especially within the gay male community, were talking about vaccinations, but absolutely not so much within the bi plus community. And that's what we're here to do tonight.
I was about to say, so, I've heard kind of two things from everyone's experiences that I think we should kind of build upon and unpack a little bit more. So I'm hearing through friends and networks, but also I'm hearing specifically if you are connected to gay community or you're seeing MSM advertisement or gay advertisement, targeted advertisement, that's where we're starting to kind of hear information. Obviously, that's less than ideal. Why do we think this is the case?
Yeah, so I didn't have any health promotion targeted towards me at all. And I heard about the changing of the criteria through you all. And so the way that I heard the discussions about it was that through Sydney Bi Plus Network, we've been talking about HIV related stuff over the past couple of years. And so people were coming to me asking about, hey, so what do you know about monkeypox? And actually raising quite a lot of concerns, being like, I don't know where I can get information. Like the criteria is like very strict about MSM for vaccinations. And I don't know, I was just hearing it also from the news and not getting any specific information. So I couldn't help out or share anything. And I would have loved to if I could. So yeah, it's coming from different people, unrelated people across the community.
That's interesting. Steve or Mandy, did you want to jump in there?
Yeah, I certainly saw, especially within my bi plus sexual networks, which include bi plus men, heterosexual women, non-binary people, bi plus women, that they didn't know much about monkeypox at all because they were not getting targeted information. And when I sort of would bring forward monkeypox information, because I think it's really important to talk about health issues that affect our community, they were not necessarily receptive, especially the people that aren't so community connected, because it's being labeled as sort of a queer health issue, or much more specifically a gay male health issue. They just thought that doesn't affect me. That doesn't sound like that's part of my networks. maybe I'll think about it down the track. Luckily, the case that we're in at the moment, we're seeing very low cases, but as Dr. Rita said, we will likely see more cases come up, and we'll see that dreaded curve that we're also used to seeing with viruses. And so I think it's really good to be on the front foot and look at how we can do more appropriate messaging towards these people, towards the people that don't necessarily follow our queer health organizations online, because it's really important through these personal connections and these networks to have those discussions.
Absolutely, Steve. Mandy, is there anything you wanted to kind of add to that?
Yeah, so, similar to Ellie, like I also received no direct bi-specific health content or, messaging, even just, looking through things like media, social media, in doctors' offices, there was just nothing. There wasn't even any information, outwardly present towards people about monkeypox in general, let alone to someone who's not a gay man. So there's just absolutely nothing that was either bi-specific or even that much kind of content or information around, and even just the messaging that did exist and that was out there was very much funneled towards gay men in a way that felt very similar to how the HIV issues were first handled, and so it's sort of similar not only in kind of government responses into diseases like this, but it also prompts the same kind of community response that we all need, where we have to be like, okay, well, we all have to advocate for our own health and have things like great forums like this where we can discuss these sorts of things, because there's just no direct messaging for our community.
Yeah, and one of the things when we were all talking the panel over the course of the last few days is that this isn't an isolated issue, to your point, Mandy, and that this is something that's structurally been in place, which I think is kind of a good segue to our next question, which is, when we think about messaging that isn't tailored to the bi community, what does that mean in terms of an impact around enabling bi people to protect themselves, their community, their loved ones, and their partners? What impact does that have? Not having tailored messaging?
It means that we don't know when to go to health professionals, and then we can't necessarily get vaccinated. And then we also, if we are at risk of contracting monkeypox, it means that, do we know how to recognize it if we do get it, or do we just think, oh, that might just heal? Maybe it's very painful, you would go to a doctor anyway, but maybe they don't recognize it, because if we're not necessarily connected to sexual health clinics, and we're mainly going to our GPs, and our GPs don't even know our sexuality because they've never asked, it makes it really hard for us to get any sort of support. And also, if we're not connected to community information, how do we find out what's going on? Where are the good places to go? How do we even know how to destigmatize these issues?
And this feeds into biphobia, right? Like, biphobia is a key element at play. Just based on what you're kind of saying, what are some of the aspects of biphobia that are at play here, do you think?
So I think it's at a few levels. So we heard from Dr. Reed that it's really important for these responses to be really fast and evidence-based. And so it's all on the data, right? We go off the best data that we have. But without community connection and community being connected to public health systems, how do we get bi+ people responding to surveys if the surveys are all targeted towards men who have sex with men, and they're targeted at spaces like gay men's dominated spaces, such as Fair Day or saunas? So when the questions are all about being gay or about that identity, and not asking about sex with a variety of partners of different genders, how do we get our experiences as a bi+ community in the in the data, so that we can be then included in the policy? If you can come back to me in a minute, I'll just have a drink.
I was going to say, I think this is a good kind of segue as well, Steve, to kind of talk about, you know, that there's also not one universal bi experience, right? And so like in different spaces that operates differently for different members of the bi plus community. Like what are your thoughts on this, you know, with how biphobia and structural access issues kind of played out for yourself in your lived experience?
Yeah, certainly. So what we get a lot is sort of bi-erasure in the data. I don't think we can really tease out the data of actually how many bi plus men are getting monkeypox as opposed to gay men. And so the current messaging is quite a blunt tool. It says gay and bisexual men, but we can't say confidently here in Australia what the actual difference is. Though, as Dr. Reid did point out, it is vastly more effective, it vastly more affects gay men than it does bi plus men. However, bi plus men's sexual networks do cross over into gay men's sexual networks. There's a large scale study from in the New England Journal of Medicine that showed that only 2% of the men diagnosed with monkeypox identified as bi. And so that tells us something really, really interesting about the way that our sexual networks work. You would think that if more bi plus men were having sex with gay men, there'd be higher numbers. But in fact, the way that bi plus men and bi plus people in general, the way that our sexual networks work, who we have sex with, where we have sex, is far more complex than how we're treating it. And it really shows that lack of understanding in our data, our lack of understanding of community. And that's perhaps because we don't listen so much to community, or community doesn't speak up enough. And so for us to understand better how our sexual networks work, to explain why it's only 2%, would really require engaging with the bi plus community, because that number will go up. When we get more outbreaks, we don't know what direction the virus will go in, because it's a virus and it will go the direction that it wants to go in. And so if there were to be an outbreak within the bi plus community, or when, we really need to be on the front foot to understand best where we can allocate resources, how and when people should implement different strategies on how to prevent it, whether it's behavioral or certainly absolutely with vaccination. And that's the beauty about vaccination. It's something that we can do in advance of an outbreak, right? And so, you know, having that blunt tool of gay and bisexual men really doesn't tease out the complexities within our community.
And to add to that, the complexity within who is considered high risk. And high risk is generally thought to be number of sexual partners and number of different sexual partners. But what we're looking at in the bi plus community, we don't really know what that looks like in the bi plus community, because so many bi plus people are not community connected in the way that has been generally thought about in gay community spaces or gay men's community spaces. And so lots of people are connected to people online, but they're not really going to clubs or community spaces. And so how do we know who is actually being able to access health services if they're not going to those spaces where also all the surveys are kind of collected? So online is a really important space, and we need to know more about it. And the problem with lacking this data is that data, or the lack of data, informs policy. And if we're not including the policy, then we don't get funding allocated to our community. And then if we don't have funding, services and training for doctors and for other health professionals doesn't bring them up to speed so that we can have affirming and helpful experiences when we go into clinics. And so if we're not getting the experience that we need when we're in clinics, we might feel the need to hide who we are and not actually present as our authentic bi plus selves. And we might have to try and pretend to be someone else. Or we might just not go to any services at all because I don't feel comfortable. And so then the people at the clinics and the data shows that we're not turning up. And so that says to everybody in public health, well, there's no need because we don't exist. And so
that cycle kicks off,
it's a
right?
cycle.
The cycle
and so
kicks off
there's no
again.
perceived need for the system to change. And so this forum is super important because it's putting a bit of a stop in that cycle and being like, hey, we're here and we really want information. we want to come to get vaccinated, we want to get tested. And I think the most important takeaway from that is if you haven't been feeling included, there's reasons for that. And I just want to validate any struggles that you might have been having. And it is really hard, but I'm really glad you're here today. And thank you for coming today. And there's been some fantastic work that we don't have time to talk about today in breaking the cycle so that BIPOC people can get the help that we need, the health care that we need. Yeah.
Thank you so much, Ellie. So many incredible points in that. And I think it's a really good, it's also a really kind of good pathway for us to start talking a little bit in focus around experiences getting vaccinated. Dare I ask the panel, has everyone here been vaccinated? Steve, talk to us about your experience. How was it?
So I wasn't able to access the vaccine in Australia before I headed to Canada, but the Canadian government offered every foreigner vaccinations, which is incredible, especially at the time. And so I received one dose of vaccination. And I just got the jab in the arm. I got mine intramuscularly. So I didn't get the little dot, but I'll tell you something really awesome. I was out at a few parties on the weekend, or a couple of weekends ago, and a bunch of people were standing around showing off their little spot. Now, a lot of people, don't. A spot on your arm from a monkeypox vaccination can be dangerous for people who aren't out, who don't necessarily want to talk about those things. But for a lot of people, they were using it as a source of pride. And I think that's one of the awesome things about the queer community is that we embrace these things. We listen to the science, we listen to our community organizations, we listen to each other especially, and we go, yeah, this makes sense. I don't want monkeypox, so I'm going to go get vaccinated. And they were all just standing around showing little spots. And I just thought that was such a cool moment. And that's the sort of energy I'd really love to see around vaccinations. Vaccinations, check out your own risk, talk to your friends, talk to doctors about what to manage what you believe your risk is. But the vaccination is very well taken by the body. It's very well accessible for many of us. And it's something that everyone can consider. And it's, dare I say, cool.
You know what? I don't know if any of us are qualified enough to say that something is cool, especially now that I've turned 30, but I think it's a really, really good point. And you're absolutely right to point out that that's the energy we really want to foster, right? Like we want people to feel excited now with the change of these, criteria, now with access being there because we have the vaccine. And also, we're making efforts like this to really actually engage with by community around vaccination. I'd really like to flow with that momentum as well. Phil, jump on in here.
Yeah, like I guess I just wanted to say that some of our clinical services probably don't get this right, all the things that you have spoken about so honestly, and there's always a vacillation between how much should we be focused on what in medical sense we might describe as the biological risk, if you like, or what is something completely separate to somebody's sexuality or their identity around their sexuality, and we kind of sometimes back away from it. I think because I think we probably we understand different bits and pieces around what we would gay men coming to our services, and we're coming to try and be a lot better about trans and gender diverse people coming to our services. But I don't think we really do represent people from the BIPOC community hugely well. And I think that throughout this monkeypox vaccination program, as an example, we've got a reasonable amount of feedback. Some of it was positive, some of it was about how it rolls out, and so I think this sort of forum and kind of what you were talking about, Elise, was hearing the voice and what I guess makes me think about how open we are to hearing you know, the voices of people from the BI+ community, and just encourage people to provide constructive feedback if they do experience biphobia or experience that a service wasn't appropriate for them. We do try to get it right when we can, and I acknowledge we often don't. So I just thank you all for sharing that. I think it's really important.
Thanks, Phil. And ditto the same here for ACON as well. So, you know, in our effort to, and I know that, Phil, you would have had many a sleepless nights when, you know, the order came down to quickly mobilize and get some clinics whipped together in a heartbeat. And I know that it felt very much the same on ACON side of things. And the reality is that, you know, we did, you know, at least from when I'm looking at, you know, our communications, we didn't really do communications that specifically focused on communicating to BI+ community members. And I think it was really awesome that the network did advocate and point that out, because it not only led to this forum, you know, but it also it contributes to that ongoing conversation and accountability that we all need to kind of hold each other too, so that we can all improve. But Phil, you know, I remember working as a peer within one of your clinics, and it was great. It was a wonderful experience. And I do think, you know, overall, you know, they are really affirming spaces, but like everything that we do, we can always, you know, kick it into gear. So I'm really glad as well that Ellie, Steve, and Mandy, you've kind of shared some insights. Mandy, I realize we didn't get you involved in that question. Is there anything that you wanted to add in there to talk through?
Not particularly. No, I don't think so. I think it's all been very well said.
Okay, awesome. Ellie, I know that we kind of skipped over it. So I want to quickly circle back. I remember you saying to me when we were kind of talking about monkeypox, and when it landed, you had a question that popped into your mind that I know that potentially a lot of our attendees might have had pop into their mind. Are you able to kind of talk us through that really quickly?
Yeah, so the question I have, which so many BI+ people have, is, am I bi enough? Am I queer enough for the vaccine? Can I go to the surface? Can I go to the service? Will I be accepted? Because, you know, maybe, well, for me, I don't look very queer, whatever that's meant to mean. And so I often kind of think, and also there's all these stereotypes about what being queer is. You know, am I cool enough to be queer? You know, am I sexy enough to be bisexual? Are people having these questions? They're valid questions, but it's important to know what BI+ means. So BI+ is an umbrella term, and it means someone who is attracted to, someone who has sexual or romantic attraction to people of more than one gender. Not necessarily at the same time, not necessarily the same way, and not necessarily to the same degree. So it's a really broad definition. And you can identify with so many labels within that umbrella. You can identify as gay and BI+, you can identify as straight and BI+, you can identify as pansexual, panromantic, fluid. You can just not have any labels at all. And that's really important, because you can just be who you are. You don't need to necessarily put yourself into a box. Personally, I do use bi and pan as labels to identify myself, but to be honest, if I was actually to write about my sexuality, it would probably be a few essays, a few pages long. So I don't think the researchers would like me trying to fit that into their multiple choice questions. But
we'll find a way, Ellie.
Sexuality is huge. And so when I think about if I'm bi enough to access services, or queer enough, we acknowledge that there is a lot of gatekeeping within queer community spaces, about not being allowed somewhere because you're taking up resources from someone else. And so that's why it's kind of really important to look at the criteria. And often that is looking at sexual behaviors, and that's the best way to go about it. But also that can be really confusing to try and pick apart when the sexual behaviors don't really match on to how you see your identity. And then me knowing what I know about data, it's like, well, have they actually considered me in what's going on? And so I have to think, well, am I high risk? And so for me, like, my partner is a genderqueer bisexual who has different anatomy to me. And they were around when all this was happening. They were planning on going on an overseas trip. And so if they contracted monkeypox while they're overseas, what would that mean for me? I at that time couldn't access the vaccine. It was a bit scary, to be honest. And
where are you at now? I'm curious with those changes. Sorry to jump in, but I'm curious.
Well, now I want to get the vaccine. I haven't gotten around to it yet because I just haven't followed up the link, and I saw someone put the link in the chat. So it's just one of those things that I just need to do, but it's just, you've got to do the steps.
That's right. So what we'll do now, so Tim, Amber, we're just going to jump onto that booking website. We'll get you sorted in a heartbeat, Ellie.
I'll just follow that link.
Yeah, exactly. Follow that link.
On my to-do list, I'll put it in my calendar. We'll put a date on it, and so I'll do it. It's just but yeah. So trying to figure out my risk was a bit hard because I didn't see myself in the criteria, and I tried to kind of read in between the lines. And I know that my partner was able to get information and vaccination because they're able to disguise themselves and fit themselves and cut themselves into the MSM box. They shouldn't have to do to be able to get a vaccine at that stage. But at the same time, if they're not considered MSM, then adding gender into it is just adding a whole nother level of questions around, am I high risk? And then also, am I high risk enough to take vaccines away from someone else? And there's a lot of guilt associated with that. And public health decisions are really complicated. And I'm not expecting myself to be able to know the answers of those big questions. But it's the question that I sit with.
And speaking of big questions, I can see us getting flooded with questions. Ellie, I'm so sorry. We're going to have to really dive in on those questions. Steve, you had your hand up really quickly. Is there something you wanted to kind of jump in on here? And Ellie, thank you. All really incredible and important points there. Steve, do you want to jump in here?
Yeah, so I wanted to jump in on something that Ali said, like the notion of not being bi enough and not being queer enough, but there's also the notion of being too straight to be able to access monkeypox information, monkeypox vaccination, these sorts of things. For a lot of bi+ people, many of our partners aren't within the queer communities. They're heterosexual. A lot of the people within my sexual networks do not identify as queer. Even some of the men, they might be heteroflexible, do not relate very much at all to the resources that we're putting out for queer people. And there was a question here in the Q&A about if there are resources available to hand to heterosexual partners, which is a very important question for us as bi+ people, because we do need to educate our partners when there isn't the available resources that are tailored for people. We can tailor our own messages to the people around us. We can tailor the information to our partners. And so I don't know about any specific resources for heterosexual partners, but what you can do is have those careful conversations with them and actually make the point that because you are a person, the current criteria do say you have to be a person who is having sex with cis or trans men who have sex with men, including gay and bi+ men. But if you are you are a heterosexual person who has sex with that group, you are eligible for the vaccination.
Yes.
And that is something that you can very confidently tell your heterosexual partners. And I'd encourage having those conversations about it.
Yeah, absolutely. And to add to what you're saying there as well, when you make the booking, there's 4 criteria that you can select. And the last criteria is criteria D. And that basically says, I don't necessarily fit in with either of the first 3. And Phil, please correct me if I'm wrong, but my understanding is that still means that people can still access vaccination and a booking if they've opted in at that stage.
Yeah, and I think the expanded access. So we've got these 25,000 doses that'll stretch out to 100,000. In about February, we're going to get another 100,000 or something like that. So, you know, I would encourage people to book in. If it's not resonating with you, then we can take that feedback and try and make it more appropriate. But you know, we understand that people's risk is difficult to codify in a survey or a tick box, and you know, there will be people's individual circumstances which aren't reflected there, and so that option is available then.
Excellent. I realize we've got 20 minutes and we have some community questions that have been boiling away. Let's dive straight into these. Thank you, panel, so much for the conversation so far. It's been awesome. Our first question comes from Emily. So NCIRS studies with Genos and its rollout in Victoria have evidence of 99% male uptake of the vaccine. As a health professional and the limited places to get the vaccine, although now granted this has expanded, both these factors make me feel ashamed to want to be safe and to seek a vaccination. Is there some way as a community we can make things feel socially safer for the uptake of vaccine for bi, gender diverse, genderqueer and trans people? What does the panel think? If you could just kind of give me some key points to make things safer. Steve, did you want to start off?
Yeah, I think something that our community is very good at is coming together and creating information for ourselves that that is relevant for us. And that means having the conversations around monkeypox with your partners, with community, with friends. In terms of making it safer, I can only speak from my own perspective. And that would be from a cisgender male perspective. One thing that makes my community unsafe, bi plus men, is the stigma that's attached to monkeypox. And so one way that we can, because when we talk about safety, we can look at safety from the virus, but also something that really impacts us is stigma as well. And monkeypox is a highly stigmatized disease. And so in terms of protecting us from the virus, we know how we can be safer in terms of getting vaccination when outbreaks occur, behavioral changes. But those behavioral changes as well can negatively impact people. And we can look at the way that sort of stigma would impact our own communities or ourselves. I know that for bi plus men, there's the stigma attached to getting monkeypox. And so we see sort of comments like, we'll just stop having sex with bi plus men. And so that makes bi plus men feel unsafe in these sorts of spaces. Especially when it comes from both outside the broader community and also within the bi plus community. And that's something that the community itself is responsible for addressing. And so for other people for other groups within our community, we have to look at where the sources of that unsafety and what we can do to actually combat it. And that's usually just through facts, through conversations. And unfortunately, it takes a lot of confidence as well to be able to talk about these things. It is labor for us to do health education, but I really think it's just so important for us to have those conversations.
Excellent. Any really quick additions that the panel wants to make there?
Making those spaces safe is really hard. And I have to kind of mask and reduce down my identity when I try, and I have lots of intersections to my identity and try and just make it as simple as possible to be able to try and access the healthcare that I need. And in terms of better advice, which is not that, I wouldn't really recommend that, but that's what I do. Knowing your right to safe and affirming healthcare, and also being able to challenge stigma. And yes, the stigma looks like discussions with people one-on-one, but also stigma looks like that systemic stigma. And so the way that I was able to feel justified in actually knowing my right to safe healthcare was looking at the research and unpacking that and realizing why BIPOC people haven't been included in the research, and therefore policy, and seeing that big picture, not just looking at it on just a one-on-one lens. And if you're not a research buff like I am, there's some great sort of YouTube videos on the history of the BIPOC community, and some information about the BIPOC community and the HIV pandemic and epidemic. So if you want to get into that knowledge, if not, connect with community, and I'm sure you'll hear lots of stories of similar experiences at Sydney BIPOC Network at Facebook.
Excellent, excellent. Mandy, really quickly, I'm going to ask you a question, and as well, it's open to the panel. So let's assume you've got to have a chat with your partners about monkeypox. How do you think you'd go around having that conversation? And did you have any tips or tricks around how to have that conversation around monkeypox?
Well, it's quite similar to having any other kind of health discussion with an intimate partner, in which you just kind of sit down in a very neutral, non-sexualized setting. You just say, hey, can we just have a chat about some health stuff, and here are some things that we can do to protect ourselves and each other and other people. And it doesn't always have to be a big, scary thing. It's just simply having an open and honest conversation about whether or not yourself or your partner or other people that you might be involved with are at risk, and just working out how to best look after each other in those situations and going from there.
Amazing. And I know that we've talked as well about what it's like to have that conversation external to other bi people. Did you have any thoughts around, say that you were having that conversation with someone who wasn't bi and there was a lot of resistance there? How have you navigated that in the past?
In the past, the best way, speaking from a couple of experiences, is that the best way to kind of have those conversations is to just make it more about the safety of one's own body, rather than necessarily tying that experience or that risk to your identity, because that's how some external people may link that stigma. By saying, well, you're getting this because you're involved in X, Y, or Z community, or venues, or whichever. And just doing your best to kind of support each other through that experience. Have conversations about when certain extra safety protocols might be able to be dialed back. Some things aren't necessarily forever in terms of taking extra safety steps. Some are, and that's also okay. So just having those conversations about how to minimize your risk of getting anything, and how to really best look after each other and also your own bodies as well.
Amazing. So many useful tips, Mandy. I'm pro having this conversation by the sounds. Steve, did you want to kind of add in anything here?
Yeah, so Mandy gave the scenario of discussions in a non-sexualized setting, but we may find ourselves in the middle of an outbreak, which I did in Canada, and having one-on-one conversations in the heat of the moment. And if we do come to a point in an outbreak, we need to know how we can manage our risk in those spaces. So there are broader things like being vaccinated is very, very important. And then there are behavioral things as well. So during an outbreak, you might want to reduce your number of partners, or have a sexual bubble, those sorts of things. But when you're in the bedroom with someone, there are some really simple steps that you can take. Ask someone their vaccination status and tell them your vaccination status. You can assess whether when I was in Canada, I asked for consent and gave consent as well to have a check over our bodies for lesions. Those sorts of things. Consent is very, very important in those sorts of contexts. But having just really upfront conversations about monkeypox, talking about your recent sexual history. Have you had sex in the last few days? Have you had sex in the last couple of weeks? These sorts of things are really important. And that's sort of individual in the moment risk sort of stuff. when we see messaging around like gay and bisexual men are the ones most affected by monkeypox, it might be tempting for us to sort of go, well, then I'll just stop having sex with gay and bisexual men. But that ignores the actual one-on-one risk. And there are those sorts of questions: have you been vaccinated? Having a look over for lesions, asking for your recent sexual history. Those sorts of things are much more finely tuned than just saying, I'm not going to have sex with this whole group of people. Because that's actually, for us to say, I'm not going to have sex with bisexual men, that's incredibly biphobic. That's stigmatizing towards bi men, and that's really, really damaging. And it's the same thing as well for bi men as well, to change their behavior and say, well, I'm going to stop having sex with men and just sleep with women or non-binary people. That's also, in the short term, I hesitate to say that might be a little bit effective, but it's really actually harmful to people, for us to have, especially for bisexual people, for bi plus people, to separate out their partners by gender. That's not a healthy thing. It will cause a great deal of distress within our community. And so it's really practical things: vaccination, behavior, checking your sexual history, checking the body, being really open and honest. These aren't embarrassing topics. Hopefully, as our community learns more about this, they'll be more willing to have these conversations and just being really upfront about it. And it's like, it's a cool topic. It's fine to talk about.
Yeah, awesome. And I think, normalizing things is really important. And also, no, you should absolutely not have to fracture and split up your identity just so that you can avoid. Do you know what I mean? Like, that shouldn't be the way we go. I do want to zoom in on some questions that we got, Phil, specifically around like risk and side effects of the vaccine. And thank you, Steve and Mandy. So, Phil, some questions that we got is there an increased risk of monkeypox for sex workers in regional areas? Was the first one.
Well, not specifically that I'm aware of. None of the, like within New South Wales, the majority of the cases were in non-regional areas. So majority of the 56, I think about 45 of them were in southeastern Sydney or Sydney Local Health District. The issue, I guess, around regional and also sex work, in my mind, would be, your capacity to be able to access, I guess, non-judgmental or aware services about what your particular needs might be, particularly if you are. Certainly many sex workers move through regional towns. They don't really live there. They might go there for a few weeks to work and then move off and move somewhere else. And so I guess, I'm not aware of any specific risks, but I think the access to healthcare issues would probably be the ones that would be foremost in my mind. If the person's online and they have a particular, if I haven't interpreted that right, I'm more than happy to answer that again, but
No, that sounds about right. The other kind of question to this as well was, are bi women at risk, and have we seen cases of monkeypox within this community?
Well, not in New South Wales, at least. So globally, as we've all identified here, the data doesn't pick up perhaps the level of detail that would be most helpful, but over 98% identify as male. We've discussed it as well, of course, by women. It depends on the risk of your partner. So if your partner is at risk, then yes, you're potentially at risk from that person, regardless of their gender or sexuality either. If we look at particular issues related to cis or trans women, we noted that in cis women, about a quarter of the infections that were seen, and the number of infections studied was low, but almost all of the trans women or transgender women seemed to have sexual acquisition, whereas there was about a quarter of the cis women in the study who maybe caught it from some other mechanism, maybe household contacts or what are called fomites, so non-sexual contact through household objects and surfaces and so forth. So there probably are some slightly different risk factors in that group. Anybody who could conceivably have a baby, there are some specific risks and concerns there, I guess. Monkeypox can be transmitted to a fetus, both in utero and also through delivery. We don't have very clear guidelines or protocols there, but if a person who could conceive is at risk of monkeypox, then I would be, if they were at risk of pregnancy, I would be, wanting them in an environment of an outbreak. If they weren't wishing to get pregnant, to offer good contraception during this time, particularly. There's been a study of about 20. They're all cis women, I think, who gave birth and had monkeypox at the time, and fortunately, I think most of the babies were okay, but there's certainly some studies from Africa showing babies stillborn with monkeypox and significant other issues as sequelae.
Excellent, thank you, Phil. And so I think that taking advantage of these new criteria and the broader guidelines will be really essential then for anyone in community who identifies that they might be at risk. I just want to quickly finish on, because we do only have 5 more minutes. So we've talked about a lot of stuff, we've covered a lot of things, and you've all each shared tonight your experiences around navigating a system which doesn't work for you or other by people. What impact has this had on you, and what can we be doing better? And Phil, maybe as well, if you kind of want to tack on to the end of this as well, that would be incredible. So who would like to go first?
I'll go. So I think one of the things that the health system does have is that there is this very classification system of funneling people into, are you this or are you that? And as a result, that can leave a lot of people, like all of us, feeling very excluded. So that does mean that there are some situations where you may be subjected to biphobia in a healthcare setting. From personal experience, I find this mostly happens in GP offices. And so for that reason, something that, we might be able to recommend is to go to a sexual health specific service or another service that is bi-friendly. And, similar to what Ellie was saying before, like I've had to, go through to certain services, and I've really compartmentalized different parts of my identity depending on what, treatment or information I needed to access at the time. Like, do I need to go to an Aboriginal healthcare service? Do I need to go to a, queer friendly service? Like, where do I need to go to get the exact thing that I need? And then when I get there, you almost have to practice saying what you're going to say to a doctor to make sure that you can access the exact thing that you want to get. So that's not necessarily the most healthy approach, because, by doing that, you're kind of, erasing part of your own identity, which is not very affirming. So that can also be, very depressing and make you just kind of feel more isolated. So it is better to advocate for your own health. So you can do that by having a good understanding of your rights to safe and affirming healthcare, having a look at, what needs to, who's actually qualifying for, what vaccine or what healthcare or what test you wanted to get, and making sure that you're armed with that information. So whenever we go into healthcare practices, we're always ready for battle. We're going in, we've got our info, we're ready to fight any potential pushback that we might get. And by doing this and challenging any stigma that does come your way, it's not only great for you to be advocating for your own health, but it's also going to be really validating for your identity. And if this, obviously this takes a lot of confidence, and it's very scary to do sometimes. So one way to kind of also get a bit more, confidence or inspiration to do this is to also reach out to other community members and see who else has some experiences. Even if it's sharing negative experiences, you can still find solidarity within that and find strength together to push back against that. But you can also find a lot of really positive experiences, which might help give you ideas or just inspire you to go, hey, yep, cool, I'm going to, go in, I'm going to be well informed, and I'm going to advocate for myself. So those are some things that we can do to really push back against the system that's not necessarily always designed for us and our healthcare needs.
Excellent, thank you, Mandy. Steve, would you like to go next?
Yeah, the way that the system looks at me so often is that I'm a man who has sex with men, MSM. But what it doesn't acknowledge is that I'm a man who has sex with men, I'm a man who has sex with women, I'm a man who has sex with non-binary people, and just like the full diversity of what it means to be bi plus. And so the way that affects me is that I just don't get the messages, the programs, the services that I need that actually see me as more than just a man who has sex with men. But I'll draw an example of what we can do, of what we've already done better. I mean, it's monkeypox related. I mean, ACON released the pause, prick, play promotion for monkeypox vaccinations. And what they did there was show for their segment targeting bi plus men, it showed a bi man in a relationship with a woman in an open relationship. And I just think when I see that, I just think that's so awesome that we're not treating bi men as just MSM. We're actually looking at bi men's full experiences. And it's really nice to be able to see yourself on the screen in health messaging. And not only does that like give you like a warm, fuzzy feeling, which is great, but it makes us actually think, oh, that looks like me. Maybe I do need the vaccination, or that reflects my experience. Maybe I do need the vaccination. And that sort of messaging, that's what we can do better, what we've done, and let's just keep doing it.
Amazing. And also, like, it feels, how incredible does it feel to see yourself in health promotion, right? Like when you go to a space and you see people who look like you talking about the things that matter to you and the sex that you're having and, the relationships that you're having, it's pretty special and empowering.
Yeah.
Amazing. Thank you, Steve. Ellie, you're next.
I think the way that not being seen in the health promotion, how it affects me is I feel like I'm not important, and that really sucks. And so whether it's not being spoken to, maybe it's not being included in the criteria originally, like I'm confused and scared about different infectious diseases. And so when I want to go out and find information, maybe I want to be told, okay, we can't get a vaccine to you right now, and cool. But what I want to know is that my experiences are important, and if I'm looking for information, that I really want to be able to find some sort of information that's relevant to me. And so what's been really helpful for me is finding community with other people, and so I get to talk to bi plus people, and I get to know, oh, you're also having similar experiences to me, and similar challenges, and it helps me realize that my experiences and my concerns are important. And particularly through the bi plus community, I've been able to explore what are the cool things about being bi plus, and not just about health and health information, but also I can get health information more quickly. And so that's been really great, and it's taught me how to care for myself and care for community. And
I was going to say, what do you mean you don't want to just talk about sexual health all the time, every day, any day? What do you mean we don't talk?
I like to know about like the cool puns from the bi plus community and the great food and picnics and stuff like that. But yeah, I also am really excited about forums like this, and I would love for the direction to be for us to go into is resourcing the bi plus community more, to be able to disseminate information to the bi plus communities.
Absolutely. Ellie, thank you so much. Phil, did you want to jump in here?
I guess my reflections are, well, first of all, it's been fantastic to hear from the panel and also the participants in the session. I think that it highlights for me the public health, delivery of public health is about allocation of scarce resources, right? Fundamentally, and to the right area. And inherently there we categorize people by all sorts of things, age, gender, sexuality, ethnicity, also income level, geographical area, and so forth. And that's done, I think, often with the best of intentions to try and maximize population health benefit for an intervention that we may have a limited amount of. And I think that the conversation that we've had this evening, really encourages me to make sure that in that process there is representation, and there is also reflection and review of what is appropriate and how are we best making these decisions between one group yes, one group no, and what is the voice and how ready are we to change those decisions when the evidence changes or when the I guess access or rights of people starts to be diminished. So it's been really useful. Yeah.
Brilliant. Thank you so much, Phil. We have gone over time and Zoom didn't kick us off, so that is a miracle in and of itself. I want to thank the panel so much for all of your hard work and time on this forum, and also thank you so much for all of the community members who came and showed up virtually for this event. If you do have any other questions, I will be sending out an email after this event, probably tomorrow, and that will kind of have some extra resources and support information for anyone looking for more support and for more information. It'll also have my contact details, so please do reach out if you do have any questions, and also please make sure to connect in with the network. I'm so excited to see what is around the corner, even though I dread to say that because I know that everyone is loving but also fearing World Pride, given that there's probably a lot of work happening during that time. So look, thank you so much, everyone. Have a wonderful night, and we will see you at our next forum. Bye.